thank everyone for joining us, and I really want to thank our panel, our esteemed panel, for taking the time out of very busy days. I can see folks in labs, in offices, and other places, um, taking the time to join us to talk about kind of stroke workflow and what the effect of AI has had on practices and patient experience, and also the physician experience. So thank you, Dr. Quill Turk from Prisma Greenville, Dr. Don Frei from Swedish HCA Denver, Dr. Jay Mocco from Mount Sinai, New York, and Dr. Adam Arthur from Sun Therapy in Memphis. Want to go ahead and get started, and I'll be just posing some questions that we've collected ahead of time. The plan is to go through those for the first bit, and we'll see how things roll. To everyone listening in, please feel free to submit your questions. You can send them directly to myself or put them in the Q&A chat, and we'll get to those for the second half. But we want a nice and interactive session. So start off, the first one, I'll start with you, Dr. Frei. What has your experience been with Viz at your site? What was stroke like before, after?
We've had Viz for probably over a year, and our practice is a little different. Swedish is our busiest center. We have about 55 hospitals that refer in from 5 states. And to be honest, because of the multiple networks, hospitals, states, and PAC systems, the majority of our transfer patients, we never saw their imaging before they got here. And now with Viz, we're able to see the images of most of the patients. So we're much more efficient at sensitivity and specificity. Who needs to come in, who doesn't? Do we need to repeat imaging when they arrive? If they've had imaging in another hospital, I've seen the images, and it's been less than 90 minutes and their exam's the same, we take them direct to the angio suite. So we're able to shave a lot of time off on door to recanalization. We're much more efficient. We're able to see their images and triage them ahead of time. So for us, Viz has been extremely impactful. And we're now doing stroke at 3 different hospitals. So to be able to know if you're going to treat a patient or not saves us so much time. We don't have to drive around for no reason. We don't have to call the team in ahead of time for no reason. So we're much more efficient now than we were before. It's been a real impact in our practice.
I open the question to the rest of the panel.
I'll happily chat in. I think that I would second what Don said. I would say that there are definitely cases where the AI component comes in incredibly valuable, where for some reason we don't have that many outside hospitals. There are our own hospitals or in another location, but the radiologist there may not recognize what is on the imaging, that M2 is occluded or whatever. And there have definitely been a lot of sort of once every quarter, oh, here's a case that the AI saved, here's a case. But I would almost say that's the less exciting part of the technology, because for me, and I think this is what Don was getting at, the power of having the images up on my phone right away to be able to look at. I could be sitting at my desk and a stroke alert come in, and I'd rather just as soon just whip open my phone and window it and zoom in and zoom out and change my views than bother logging into my PAC station that's right next to me. So that's what I love the most about it. I think the AI is great, but fundamentally the interface is kind of my go-to. That's the big difference on my end. I don't know what the other guys think.
Yeah, I'll third that. It's a very intuitive, very useful, high-resolution way to interact with the imaging. And my experience in Memphis is that we work with multiple systems. And so logging into PACS, using all of the security measures that you need to use to, get a PACS view that really isn't optimized for seeing cerebrovascular anatomy or looking at an aspect or looking at a perfusion is a much inferior way for me to be able to make decisions than using Viz. So the two things that have already been emphasized that I think are huge are the ability to shorten the time in communication and the ability to really have a very meaningful way to view the imaging and understand what you're looking at.
What about you, Quill?
Yeah, I've got the same experience. I mean, the ability to simply pull out your phone, it's right there on the app. Everything you need is right there. It's almost like Apple made it. There's not an instruction manual. It's intuitive, as Adam was getting at. It's just very easy to use, and most importantly, it's the images that we're used to looking at. It's the axial images that you can then create your own MIP from right there. You can zoom it. You can change it to however you want. Window and level it very easily to optimize what you're seeing, and to do that on your phone. So if you're on call and out at a restaurant or you're doing something else, you don't have to stop, go find internet, pull up your laptop. It saves a tremendous amount of time. It really works on the efficiency of the system, especially when engaging with outside institutions.
Yeah, I can't stress the importance of having the doc who's potentially going to be doing the thrombectomy have the ability to look at the images themselves and not wait for or trust might be a general radiologist in Montana, or one of your partners that is 100 cases behind on the queue. I mean, you got to be able to look at the images yourself. The neurologist can look at the images too. You can communicate with the stroke neurologist who's seeing somebody on a telemedicine camera, and that's huge. I mean, for us, that's huge to be able to look at it yourself.
So the other part of it that I think is really big is the integrated messaging. So you're looking at it yourself, the stroke neurologist is looking at yourself, and you're texting right on the platform, hey, have they had their COVID test? Is the weather good enough that the helicopter can fly? It's really a great package to include the communication. Sorry, Quill, I didn't mean to interrupt you.
That was where I was going as well.
It's also helpful to say, hey, is the family there? Can you get the number? Can you communicate to us? Can we call them ahead of time and have a lot of the conversation? And we still got to do our in-person consent, but if you can get a lot of that done while the patient's en route, I don't know. It's just completely transformed the workspace, and we've seen it numerically in our times to treatment. It's quite dramatic, the concrete effect that the institution of Viz has had on our system.
So Dr. Mocco, it's a great point you bring up on time treatment. Is actually the next question I have is, would love to hear from all of you on how you've seen Viz affect your time to treatment for patients. And I do have some slides that you've all submitted. I'm happy to bring them up and share them as each of you chime in.
Quill, you want to go first on this one? You want to take this?
Sure. Yeah, I mean, I've been in Prisma Greenville for coming up on 2 years. The folks that were there prior to us, they favored Rapid, and that was what was there prior to us. I personally didn't use Rapid that much. It was something that the neurologists that were there, they got the perfusion images sent to them by email. It wasn't something they could share with anybody. You had to arrange for it to go to your email, and then you had to go check your email to then get it. So it wasn't something that we used a huge amount. But it did certainly help the neurology groups that were consulting us make their decisions and feel more comfortable. Call on this one, don't call on that one. Our times in general were, as you can see, somewhere around 70 to 75 minutes from when the patient hit the door to arterial puncture. When we switched to Viz, it was in the middle of Q3. We were able to bring it down a good bit to 61 minutes and then down to about 50 minutes. And at the same time, during all this, our volume was up, virtually double during this time frame as well. When we got there, they were doing about 60 cases a year. Our first year there, we did about 130. And the second year, the second year, we were on pace to do almost 250 until the COVID hit. And then that really put a damper on our cases, but has also really changed our system and how we are learning to address these patients and bring them through the system. And I think that accounts for this bump back up to 60 here in Q1 2020 was, March hit us pretty hard. But overall, I think, really, and also in talking to our members of our team, more just to kind of, hey, how is it going? What is your thoughts on this? What do you like? What do you don't like? Everybody universally does favor Viz because, they all have their own individual things that they like about it. But in general, it does all favor around the easy ability to look at images and the easy ability to communicate back and forth to the team.
Adam, what do you think?
Do you have my slide? So these are data from that's interesting. These are data from a manuscript we've got coming out, but it looked at a cohort of 100 strokes before and after Viz. And what I'd highlight to you is the CTA to first notification in minutes dropped dramatically from just under a half an hour down to under 10 minutes. Bev Argard, Keenitz had just asked the question, do we have proof positive that this has resulted in a lower length? Good Lord, while I'm talking to you, I'm getting a Viz alert. Proof positive that it's resulted in better patient outcomes. And Don, I think you've got some slides to show that. But I really think just with what we know about this disease and time, just looking even at 100 patients and seeing that dramatic notification drop is enough for me to know that this is something that more than likely is causing a direct benefit for patients. Don, you want to show your slides because you've got some better data.
Yeah, I'd be happy to. Again, it all comes down to time, and time is brain. So for us, again, if we can see the images from PAC systems all over the place, from everything, which we were not able to do before the majority, and most of our patients are transferred in. So now that we can see the images, we can triage these patients and bring them direct to the angio suite and not repeat imaging. So our daughter recans have really dropped, and our patient outcomes are better because we're getting their vessels open faster. So I can't stress how important it is, but the data is clear. I mean, if you're getting daughter recans, we were pretty good before at Swedish under an hour, and our other two hospitals that are much less mature, those times are dropping too. But now with Viz, we're daughter recan in 45 minutes on average. So those patients, of course, are having better clinical outcomes in 90 days because we're faster. And we need to be faster because we all had a drop in the number of LVOs during COVID, but I don't know about you guys. This summer's been insane. I was on call last weekend and I did about 12 strokes from Friday afternoon to Sunday night, and it was busy. And what we presented several years ago at SNIS is that, for the number of thrombectomies we do, that's only about 20% of the times we're alerted. So, a couple years ago, we did about 250 thrombectomies, but we're getting called in for like 1,300 potential thrombectomies. And that's a lot of time that the team's coming into the hospital. And the ability to kind of triage that and only call the team in when you need to is huge for physician, tech, nurse, anesthesiologist burnout. So it's necessary now because our volume is exploding. I think we're probably now tracking on to do 350 to 400 thrombectomies this year. And I'm going to have to start having my 16-year-old son chauffeur me around, because you're driving from one hospital to the other and you're getting Viz alerted, and you're not supposed to be looking at your phone as you drive. And you're like, okay, I got to call the backup person to go to hospital B. I now have to go back to hospital A. I got to make a U-turn. This really helps us triage these patients. I can't say how efficient it is and how fast we're getting, and patients are doing better. So now our modified Rankins are much better because we're faster. Jay?
Yeah, I have a slide in there. We can pull that up. And basically, this is an evaluation of us pre and post viz over a pretty limited time period to try to not to get effects from other things that are going on. Obviously, we've had a lot of issues with COVID recently in New York City. But what you can see is we were able to reduce times by over half an hour. This is concrete. It's very real, and it made a real difference. There's actually in univariate analysis an improvement in actual clinical outcomes as well. We want to get more data so it's valid to do a multivariate, but there are some things that are empirically obvious when you're doing it, and when you have the ability to see the actual images in your hands right away, it's tremendous. Before we got Viz, we did an analysis of how many times a patient who had an LVO at one of our outlying hospitals was transferred in, but by the time they got to us, the brain had progressed to ischemia such that we didn't intervene. And how many times was that imaging to notification of the team more than 20 minutes? And it was frequent. And so it obviously leads to the conclusion that if you can shorten those times, if you can not have a patient at an outlying hospital take 30 minutes before they realize they need to call you, and instead you're proactively calling the ED because the alert's gone off on your phone and the ED doc hasn't yet checked because he's dealing with some other patient vomiting in Bay 3, and you're able to call in there right away and say, hey, you have an LVO there, like, let's figure it out. And sometimes you call in, you find out it was a chronic lesion, the patient's an IH of 0 or whatever, and but I'd much rather have that happen once in a blue moon than have the patients that are appropriate elbows that we're identifying daily and weekly have those extra 10 or 20 minute delays in their notification times. So, I mean, to me, it's concrete, separate from my own personal convenience of loving the interface and being able to look at the pictures. The fact that we can save 30 minutes on our treatment times, it reduces our door in, door outs dramatically. So I'm a fan.
All right. Thank you for sharing. I'm just switching screens. So another question for the group. How has AI changed your practice? We talked about treatment times, but are there other differences on how you're practicing triaging patients or making decisions? And then a second part to that, how do you think it will change in the future? Every week we're hearing about more possibilities with artificial intelligence. So I'd love to hear what it's done for you so far and what you think it could do in the future.
To me, I think, the way it's changed our practice is, we still triage patients the same way. We make sure they get their imaging first before they call us about it, make sure the patients are somebody that's a candidate for endovascular therapy, just so that way we don't get bothered with every single scan that's done. But what it does really do is, I think, what we've talked about here already, which is it really enhances our efficiencies and allows us to much more easily look at the images, make a decision, and get the ball moving. It lets us communicate with our team members more accurately and more efficiently. I mean, it just makes the whole process much more seamless, where everybody's kind of on the same page. I can't tell you how many times, my techs, they've got a 30-minute response time. And before it, I used to always be there setting up the machine. Myself and my nurse practitioner would be setting up the table for them because they all live 30 minutes away and I live 10 minutes away. And now with Viz, they get that alert as well. They know the patient's a candidate. they're the ones, they're already there. So they beat me now a lot of the time. So it's just, it really, for the entire team, enhances the efficiencies across the board. And I think even more telling is that, our partners who do peripheral intervention and vascular intervention, they're getting all their studies sent, emergency studies sent over to the Viz, because, for them, if they got a patient with a GI bleed or something else, they prefer to use Viz and pull it up on their phone. And it's actually kind of, very telling that they're the ones pushing and driving this. And then they're coming to us and telling us about it. So it's kind of, very, very cool on that side of it.
What do you think, Jay?
I think having immediate image-based sort of engagement is going to be powerful and broad for us on a very large level. I think that there's aneurysms, there's subarachnoids. I mean, how often are they missed in studies? You see a patient with a aneurysm, you see they had a CTA 3 years ago that wasn't picked up, or a patient comes in with a rupture and there was, they say, hey, well, I had an MRA at some other place 2 years ago, and turns out the aneurysm was there. I think bringing that to bear for neuro is going to be powerful. I think realistically, I mean, we're neuro specialists, so that's what we talk about, but this has tremendous broad and far-reaching applications for peripheral, as Quill said, as for coronary, for PE treatment, all of those things. And there's a whole nother application where you apply the same sort of algorithms and the ability to seamlessly and easily view your patient data. How about if your patient's in the ICU, and how many times over the course of your career have you run into a circumstance where you get called and the patient's exam has changed, but when you go back and look, their their blood pressure went up a half an hour before that, and there were other signals going on. And if Viz was, or something like Viz was, processing that data and sending you an alert, hey, your patient has critically changed variables and you might want to look at their vitals over the web, man, that would be awesome. So I think this is the tip of the iceberg in the kind of applications this technology, as long as Viz is true to its, not only about its managing of data, whether it's imaging data or patient data, but also in the seamlessness of the engagement. As Quill said, it's like Apple designed it, or it's like, I hear people that, I don't have a Tesla, but people who love Teslas, maybe Adam can speak, they love the interface. They love how it's not built by, gearheads. It's built by like software people that make everything seamless and fluid. That's the way I feel about Viz. And so as long as they stick to that, I think the sky's the limit in terms of how the technology helps people.
Yeah, I want to riff off of that, because the sad fact of the matter is that when we work with electronic medical records, whether it's Epic or Cerner or whatever, you're really not working with software that is built to make clinical decision-making faster and easier for patients. You're working with software that's built to help hospital administration and billing functions. And so just the fact that the focus of this effort is to improve clinical communication and clinical decision-making makes a huge difference. I think that's what we're trying to say. As doctors, there are a lot of things we work with that are not optimized in order to help us take care of patients faster or better. I'm sorry, they're just not. This is.
Yeah.
So yeah, for us, we have a pretty big spoke and hub network. So again, until we got Viz, we couldn't see the majority of these scans at all. No one could. Patient gets shipped from a faraway place, a small hospital, suspected LVO. They arrive, they don't have one. So that's where I think the specificity is really helpful. You don't transfer a patient that doesn't have an LVO. You may not transfer a patient with a completed stroke, or if you need to because they need neurocritical care, but the stroke's completed, it may not have to be an emergency. But I think the thing that AI is really helpful, because these small hospitals may not have subspecialty radiology. They may not be able to read these scans in a timely fashion. So with Viz, we can see it immediately. So we're making the call before the general radiologist may even see it on their queue. And we're calling the chopper in much faster than it would have been otherwise. So that may have something to do with the fact that our volumes are going up so much this year. But I think AI is, it's kind of the tip of the iceberg, as the rest of the guys said. Cerebral aneurysms, lobar hematoma evaluation, detection of the cause, and then everything else outside of neuro. I mean, it's really the tip of the iceberg as far as I'm concerned. We try not to let the other, the general IR docs get access to Viz. I don't want them clogging up my cloud, slowing me down.
We'll make
You're
sure.
not to play in the sandbox, buddy. Come on.
We'll make sure to keep all imaging flowing. For the benefit of everyone, I think it would be interesting to maybe compare and contrast stroke workflow at your centers. You've all commented a little bit on how it works, but maybe some of the uniqueness of things about your centers are also things that you've found that you've optimized with or without Viz, just kind of workflow at your centers.
Adam, you want to go after that one first?
Sure. You caught me looking at my third Viz alert during this webinar. So
I think the Kavi, just to restate, the question is, how has it affected our workflow?
Was on mute. Maybe you can comment on kind of workflow in general at your centers. I know that we're definitely a little bit more rural and more metropolitan areas between the four of you. Just kind of what it'd be nice, I think, for the group to hear, what does workflow look like standardly at your center? Integrate and comment on maybe Viz being a part of that, but anything that you've optimized over time and realize has kind of perfected your workflow.
I'll tell you a funny story. So we had a Viz alert, this is maybe a year ago, on a patient who was at a rural hospital that's a spoke hospital for one of our hospitals, who had a clear left M1 occlusion. And my partner, Violisa and Noah, called the emergency room. The helicopter happened to be there, and she said, throw the patient on the helicopter. They need to be here right now. They need a thrombectomy. So they transferred the patient. She did the thrombectomy. And as she scrubbed out, the director of that emergency room called her very angry and said, you guys are doing terrible things. You have transferred this patient before either the interpreting radiologist has gotten the dictation done and before my emergency room doctor had a chance to examine them. And we happened to have the hospital CEO right there when this angry call came through. And she said, would you please document this in an email? Because I'd love to have that, right? I'd love to have a complaint that we actually got a patient who made a miraculous, fantastic recovery, cared for before the traditional workflow would have allowed either the radiologist to interpret the study or the ER doctor to see the patient. Now, that is as much a praise of the change in the workflow as it is, unfortunately, an indictment of some of our existing workflows. But I guess the point I'm trying to make is, for a long time, the problem with emergent large vessel occlusion patients is that they don't get the rapidity of attention that they deserve, I think, in almost any system, but certainly in my system. This is a stake aimed at the heart of that vampire. This is, an attempt, a way to appropriately care for people who are losing millions of neurons per minute. And so the change in workflow has been to enable us to reach into that cumbersome system and say, hey, we're going to put the patient first. We're going to take care of a patient who's losing their ability to speak, losing their motor function, losing their future in the right way. And unfortunately, hospital systems are slow to respond to new data, like the thrombectomy trial evidence from 2015. And this is a way of enabling us, giving us the power to speed some of that response.
Adam, I wanna run with that comment for a sec, or something you said that maybe think about it, is that you were talking about sort of the antiquated or old ways we look at these, the old workflows and what we do. I honestly believe that you know, just like people training now can't conceive of an era when people, accuse us of being crazy for treating elbow at all. I think that there's going to be an era in 5 or 10 years where people are going to say, "What? What did you used to do? The pictures went to some doc somewhere else, and it was randomly in a queue, and they had to read it. Then they had to call, page back the ED attending. The ED, they're going to say that's crazy. That's ludicrous. It's obvious that you would do it this way." Um, I think that's what's going to happen. I think you're right. When you talk about a stake in a vampire, it really is kind of crazy that we still do things the way we did in the past. And so I think that's probably part of why it makes so much sense using it now.
I remember we put in Viz, a year and a half ago, and we go into the CT scanner at the hospital. If it's an alert during the day, we just walk over. The stroke team's in there. We give IV TPA in the scanner. So we're in the CT scanner. I got my phone in front of me. I'm looking at the images on Viz as they're acquiring the images. And we're sending the patient over for a thrombectomy because I see the CTA immediately. I can reformat it on Viz. And that's before the CT tech can do any reformats, and then they have to send it to the radiologist. So this happened 3 or 4 times in a row. The neuroradiologist would call the neurologist and say, "Hey, there's a left M1 occlusion." And the neurologist is like, "Hey, here's a picture of the clot. Frei just pulled the clot out. We're in the angio suite. The thrombectomy is already done." And then the neuroradiologist comes running over. He's like, "The Viz thing has slowed down our packs. This is all your fault." And we're like, "No, you idiot. Viz is faster than PAX, and we're already done with the case." And they were blaming Viz on the fact that the PAX system is slow. It's like, this is better. It's like, hey, do you remember your life before internet?
Yeah.
Well, this is life after the internet was invented. It's so much faster. It's so much more efficient. And honestly, it's more specific. So we come in when we're supposed to, when there's an LVO. We don't call the team in thinking there might be an LVO and then send everybody home. So the number of false alerts for us has really gone down. It's just so much more efficient too. Quill?
So let me just say something on that. It really is a decision support tool. We're also enthusiastic. I don't want anyone to get the impression that this replaces, really judicious, careful physician consideration of both the imaging and the patient's clinical scenario. It isn't. It's not perfect. We see it miss, particularly M2s, posterior circulation. We see it overcall things, but as long as you're not expecting it to be your robot radiologist and replace everything, that's not a problem. It's supporting your ability to make a decision and make a communication. So I guess we have so much unbridled enthusiasm between the 4 of us. I didn't want the audience to be left with the impression that this replaces, radiology, because it doesn't. It's not even close to that. It just helps us do the right thing faster.
Right. Yeah, I didn't need to say the neuroradiologists are being replaced. To be honest, my diagnostic partners were very concerned about AI. And now they embrace it. They're like, "Listen, I got 5,000 images I have to look at. I got a CT, I got a CTA with all the reformats of the neck and head. I have CT perfusion. I have 1 million images to look at." And with Viz, it's like, okay, it's not perfect, but it kind of highlights where you look first. It's just what they do with a PET CT. A PET CT with the merged images helps them identify cancer and metastases. This helps them focus on potential LVO, and it just makes their ability to read the huge amount of data more quickly and efficiently. So they've made a 180 turn. This is what they consider very useful to their practice.
Yeah, I would sort of add to that for our group. the radiology has been has really embraced it. And what has been, there was a concern when we were first bringing it in about how does this affect their workflow? Is there going to create, is it reading the films in some way for them? Does it have to kick back a report or something? And when we explained that, it was really just allowing us to look at the pictures just like we normally do, but we're not logging into a PACS and doing all the rest of it. They're like, oh, that makes tons of sense. And they've really embraced and enjoyed it. And I think they like getting it and getting the cue, as Don was saying, right ahead of time. I think everyone kind of feels it moves things along much more quickly. Frankly, it also allows me to have a much better conversation with them versus, if you're out at least for the way it works for me, if I'm out at dinner, I can't get into my normal PAC system and work and look at my pictures. So what ends up happening is I'm looking over my phone at a video of a scan versus when I'm using Viz and I'm getting 3D recons and I can speak to the radiologist and say, hey, increase the MIP and do the sagittal, and you'll see the M2 has a distal occlusion, and that's what we're talking about. And so it increases our collaboration and ongoing conversation with our radiologists as well.
I think you guys have exhausted this one for the most part. I mean, the only thing I guess I could really add to it is, I mean, or the only other angle that I think hasn't really been touched on is, to me, the one thing that I've noticed with using Viz in our practice is by having our techs and our nurses also on board, and having the app as well. I mean, they want what's best for the patients. They're oftentimes, especially the nurses are out, especially in-house patients, they're seeing them before we are, because we're busy looking at the images doing that. And they're just more like, let's go see the patient, see what's going on. So especially on call situations, they can oftentimes look at these scans. They are now seeing enough. They feel it increases your team cohesiveness. They feel more engaged. Like, oh, I got that one right. And, it really, I think, brings everybody together and really helps the team and the efficiencies.
Can I comment on one of the questions that's on here, and maybe some of you guys can answer? Someone had asked, why should we switch from Rapid to Viz?
Yeah, I was going to ask Quill, since he had that slide that shows his recent switching.
Yeah.
So I guess switching isn't really quite complete, because not only did we all switched clinically, but our administration was too they weren't quite sophisticated enough to read the contract and cancel Rapid in the appropriate time. So we've been running both Rapid and Viz at the same time. I think most people don't really use the Rapid at all. We've certainly looked at both of them together, but Viz is just so much easier to use. Rapid did come out with the vessel analysis part where you can look at the vessels, but it's kind of like taking a 3D MRA and drawing around the area where the blockage should be based on perfusion and merging those two together. And you're trying to look at like a 3D MRA, and that's a little to me. That's not nearly as intuitive. It's not what I do every day. It's not how I look at vessels. It would give you more of a gross, oh yeah, there's M1 gone, but it's just in your mind. If you can think of that MRA versus a CTA going through it, to me, it was much easier to everybody to do that. So yes, we actually have had both and are still have both to this day, at least for the next month or two. But Viz is for sure a lot more intuitive, easier to use, all the things that we've talked about today.
Yeah, we got Rapid after Viz because of a clinical trial, an IV tenecteplase study. So we have all of that too. To be honest with you, we rely upon CT aspects and CTA. And I do think that the LVO algorithm that Viz uses is superior, just from an engineering technical standpoint. But the other thing is that, we're looking at the CT, we're doing the aspect score. If the core infarct is small and there's a LVO, we're going to take them. I don't really rely as much on perfusion as others may, but we've actually had both for a while. And I think we have perfusion data from Viz, we have perfusion data from Rapid, and I care mostly about CT-CTA.
And Don, I'm going to just jump in on this because you and I have both published together papers on perfusion and how we use it in our practices, and how much it's helped us extend the time windows and all that. And and I'm not saying I don't believe in perfusion, but I definitely find that I rely on it much less these days. And I think that to me, aspects is important, and I think the CTA collaterals, looking at the collaterals and the collateral score, I think is probably one of the most critical components of the scan to help you determine if it's how they're going to turn out.
I'm looking at the chat. There's a couple interesting questions there. One of them, which I think is worth talking about and putting out there, is one says, how many of these physicians are compensated by Viz? So certainly that's worth putting out there and having disclosures and such. I'll tell you that we got Viz and I used it for 2 years without any compensation or relationship. I did recently become a consultant for Viz, so I do have a potential conflict of interest there. That all post-dated and became something because I became so enthused about the technology after using it for 2 years, and is a relatively recent occurrence, but it's worth putting that out there. I don't know if Don or the other guys have any conflicts, but I do have that.
Yeah, we got Viz, and we had it for over a year, and I'm a consultant now, but again, we had Viz for over a year before that relationship started.
Yeah, I mean, I've never been paid by Viz for anything. I did invest in the last round that they did, just because I do believe in the technology, but that was my own personal money making an investment. And there is discussion about being a consultant in the future.
Adam?
You have anything?
We're just talking about, have you been compensated or do you have any financial relationship with Viz?
I don't have anything to declare. I would like to have something to declare, but I don't at the moment.
Good one.
Hey, I noticed that you have the date on a sticker on your jacket. Is that what your nurses do for you every day so you know which day it is?
Wow. Pot to kettle. Come in, kettle. No, that's part of the COVID screening algorithm, Grandpa. But thank you.
I just look at the date on my watch.
That's good. That's probably more high tech.
Someone asked about it being instituted in smaller rural hospitals. I don't have much rural area around me. Don, can you speak to that?
We are putting Viz in as many of our 55 small telemedicine hospitals as we can, as fast as we can, because those are the hospitals that need this. They don't have the neuroclinical expertise there. They rely upon telemedicine, and they rely upon us looking at those images and helping them make decisions about transfer or not. So we're getting Viz uploaded into our spoke hospitals as quickly as we can. And those are the hospitals that need it the most.
Yeah, I mean, we're in a similar position where we have our kind of mothership, and then we have 6 other hospitals in our surrounding area that we own. It's easy to put them in those because those are our hospitals. We're also recently, we're now Prisma. We used to be just Greenville. Now we also have another comprehensive stroke center in Columbia, which they have their own 5 or 6 hospitals that they own and come to them. So it's easy to put them in these hospitals and have them come to their own respective comprehensive centers. But then we have other regional stroke centers that are not affiliated. And we do have relationships with those hospitals, and we have put them, or we have put them in 1 or 2 and are actively trying to put them in other ones, just to improve communication, improve efficiencies. And as far as how to do that, I think it really there have been some people who said there's no anti-kickback laws. There's some lawyers that disagree with that. It's just a matter of how you position it, how you approach it. We find that we can oftentimes offset the costs to these other hospitals, and financially it makes it worthwhile to do that if they send their patients to us. So there are a lot of different ways to go about it and different models, but that really is going at the end of the day, it's going to come down to the hospital lawyers that you work with and the hospital lawyers at that hospital as well.
Let me just comment about that, Quill. So that's a really good question. Our hospital's HCA, and HCA has created some relationship with Viz that I don't know anything about personally, but what it has allowed is that it's allowed Viz to get put in all of our spoke hospitals, and there may be a sliding scale of how much it costs a spoke hospital to pay for it, because there was a big issue about cost. These small critical access hospitals don't have money. But what we have now is that if you are a critical access hospital and you need Viz, it can be done at zero cost to that spoke hospital. Jay?
Oh, yeah. Sorry, I just had one other question I want to get in here is before we switch gears to anything else, I wanted to kind of open it up. The four of you, what's the next big thing that you feel is going to be happening in stroke? Whether it's from a technology, a device, a policy standpoint, what is there left that we need to, that you see as next?
Well, I'll take a crack at that. I think now that the mechanical thrombectomy is proven, we've got a lot to do to figure out exactly who should get treatment and who shouldn't, and how they should get treated. So it's still wide open. And then, you know, we had a question about Viz for ICH, which I think, while it shows up and it's useful occasionally, that's something you guys are working on, if I'm not mistaken, to have a specific application. And so I think this sort of artificial intelligence for communication and decision support, as Jay mentioned, is going to be useful for a lot more than just large vessel occlusion.
Yeah, I agree. And I'll sort of take the baton from there and say, obviously, I'm already passionate about the idea of this kind of an interface, this kind of a mobile integrated exchange, as Adam said before, using software that's built to facilitate physicians getting quality outcomes rather than billing practices and regulatory compliance issues. I think this represents the tip of a spear of a whole new way to approach software for physicians and how these things should be done. So I think that's tremendous. And, you know, the other really big elephant in the room is, although we have evidence for thrombectomy and we have so many other things, a lot of the time that many of us on this call spend a lot of the effort we put out is there's still dramatic gaps in our systems. Hospitals that can't recognize stroke quickly enough, extremely prolonged door in, door out times, decentralization or lack of expertise in care and provision for thrombectomy. I see that is, although it's not a sexy next big thing, there still remains a lot of work to be done across our country, across the world. And so I'm hopeful for this technology to help us achieve that as well and improve those kinds of engagements and referrals.
So I'm gonna plug SNIS here. We started a initiative several years ago called Get Ahead of Stroke, because the majority of patients with LVO are not being treated in the US or the world. They don't go to the right hospital first. They don't get treated by the right physician at all. So I think that we're all going to be treating more patients in the future because they need to be treated. If we can get the legislation in place to get the right patient to the right hospital first so the right physician can treat them, that's going to happen. What that means is we're all going to get busier. We're all going to be treating many more patients. And we need this type of technology to be able to treat these patients more efficiently and faster. But it's going to happen. There's no question about it. We are doing more, and we need to do a lot more.
Yeah, I think two things. One, I think, Viz is right now come in and focused on the triage and therapeutic aspects of stroke. But so I think one, it can probably expand up and down the continuum where it can involve EMS on the front side, where it'll accelerate the notification side and the data that EMS needs to pass along. And it can extend along all the way through into rehab and everything in between, where we're better and more effectively communicating about these patients. And then number two, I think it can more widely be focused on what it can do. Not only the mobile imaging viewer that you have today that can go into many other areas. Anybody who uses imaging can use this platform to more efficiently look at data. But it can also go into other areas, as Adam, kind of brought about, looking more from a patient outcome standpoint. So we understand the medicines, understand their vitals, understand all these other things, and help AI help us, track that and monitor it better. So I think it's, there's a lot of, just depends on, there's things you can do today and things that are going to take 6 months, a year, and then several years. But I think there's a stair-step cadence that's out there, both far and wide.
Sorry, I was mute there.
Adam, trying to talk to us.
One of the other things is I wanted to ask all of you is, Dr. Mocco and Dr. Arthur, you commented on ICH, and I know that that's a growing treatment as far as procedurally removing the hematoma. Are there, in addition to, or maybe you can talk a little bit more about ICH and ICH treatment, other areas and disease states that you see AI or software can help, whether it's the triaging, the detection, or workflow?
Copy. I think the low-hanging fruit is the high time dependent stuff where you can make a tremendous difference, or the under-recognized diseases. So I think I'm a little bit over my skis on the topic, but I think PE is probably something that this would be incredibly useful and valuable for. ICH, it's still treated as a non-emergent disease. We've kind of taken a much more aggressive approach here, and we try to get the ICH evacuated right away. We think that's worthwhile. It's unproven yet. So if that proof ends up coming along, I think it'll be extremely meaningful. Other disease states like that, I think that's, MI potentially, but things where there's a high time component, the value's there for all diseases, but I think the time components are the ones where I see the biggest impact in the short term. I don't know what Adam thinks.
Yeah, so, there's a lot of possibilities. As a neurosurgeon, one of the ones that immediately comes to mind is hydrocephalus and shunted patients, right? So we've had some preliminary discussions with Viz about building a library. For instance, for kids here at Le Bon or St. Jude, we've got a lot of patients with pediatric shunts. And could we have AI decision support to look at the ventricular anatomy in a patient where we have banked what their ventricles look like when their shunt system is working properly? So I think there are a lot of ways where AI decision support will help physicians in drawing their attention to cases that are time dependent and helping us to triage and focus in appropriate ways.
We've seen a lot of patients that have had LVOs, and they also have cerebral aneurysms. And the aneurysms are incidental, but they're missed on the CTA read because it's being focused on the acute ischemic stroke. So I think cerebral aneurysm detection for AI is going to be helpful for us as well.
All right, awesome. Well, I'm looking at the questions I've got here, and it looks like we've exhausted. If anyone else out there has any more questions for the group, please feel free. Otherwise, I'd also ask the four of you, are there anything you'd like to ask each other or the panel or share before we close?
One way I would ask everyone, I've thought about this myself, how has Viz helped us in stroke? And what if your hospital said, yeah, we're going to get rid of this? yeah, we don't want to do it anymore. We're gonna dump this technology. How would you handle that type of comment? I mean, I would say that if I didn't have Viz, I would be drowning right now. I mean, honestly, I think Viz is something that I really rely upon. And if someone told me we can't do that anymore, I would not take that one lying down.
Yeah,
Yeah, I'd be asking if one of the three of you would offer me a job.
No, I tell you, Don. I mean, I've thought about this, and when before we were at MUSC and we had a very aggressive stroke neurology team, interacted pretty closely with our interventional team, and there was a lot of communication. We didn't really see a big role for Viz in that setting. In Greenville, Prisma Health, where I'm at now, we don't have a large teaching environment. We have advanced practice providers helping us triage patients along with a fellow and going that route. But it certainly makes a huge difference when you don't have these big these large teams that are aggressively and actively at the patients all the time. As I think back on it, though, even in that large academic setting, I think Viz probably would have made our process a little more efficient and faster. But certainly I think that impact is magnified and accentuated as you start removing people from the equation and getting out of that teaching environment. And I think, so as I think about all the people out there practicing and doing stroke, I think the majority are not in these large teaching environments. And I think that's, probably, I think they'll be the ones impacted the greatest by it.
Adam or Jay, any thoughts?
No, I want to say thank you for the opportunity. And if there are people out there who have questions about how we're using it in Memphis, don't hesitate to email me. I should probably sign off because our helicopter crew is here now with the first of the 3 Viz alerts I got while I've been talking to you guys. So time to get to work.
Good luck. Godspeed.
Take care.
Thanks, guys.
Thanks, Dr. Arthur. Dr. Turk, Dr. Frei, Dr. Mocco, thank you for your time, your insight. Really, really appreciate you sharing it out with the group. And with that, I'll let everyone get back to very busy schedules, I'm sure.
Thank you, guys.
Thank you. Take care.
Thanks, everyone.